Thank you and good morning to all of you. Just taking through what Dr. Satyamurthy was talking about. What are the various corneal pathologies which can be determined for getting good visual recovery in our patients who are undergoing surgeries? No financial disclosure as such. I would like to take you through our various aspects of corneal problems. There may be a pre-operative, pre-existing corneal pathologies which can be, as described earlier, ocular surface disorder. I think that there's a major problem for a cataract patient undergoing surgery. Then you have pterygium or a post-pterygium surgery problems, corneal dystrophies, degenerations, which are so common in this age group, post-keratorefractive surgery, ocular surface problems, impact of the corneal curvature change which you produce by your surgeries, especially anterior and posterior corneal curvature. There are cases with corneal ectasia which have cataract, which may be pre-existing or post-surgery, like post-refractive surgery or post-keratoplasty patients. Intraoperative factors may be your incision as such, which may be going through so much of stress because of various surgical techniques. Then you have epithelial problems, especially in diabetic patients where you have epithelial erosions, descending membrane detachment, and trauma to the endothelium. These are main intraoperative factors. Post-op, again, persistent epithelial defects, sometimes persistent corneal edema, which is so common in patients with compromised endothelium. You have a TAS, which is not very common nowadays, but still is a culprit for corneal problems. You have post-op dry eye or ocular surface disorder, then medicines which can produce epithelial toxicity in your patients. Just taking to the pre-op causes, you have, as I said, corneal opacity patients, keratoconus with cataract, peripheral degenerations, Terens, marginal degenerations, PMD, or you have corneal scars, post-infectious keratitis, which has healed and have cataract. You have other group of patients who have undergone various types of keratoplasties, which can again give you corneal problems. Then post-trauma corneal scars, Murray's ulcer, then you have post-LASIK patients, pterygium patients. All these patients will definitely give you corneal dystrophies. Most dystrophies where you feel they are advanced enough will require a combined surgery as well. So these are patients where you feel you can do cataract surgeries, like epithelial basement membrane dystrophy, which normally presents at recurrent epithelial erosions, and that can increase after cataract surgeries. Granular dystrophy, where we do cataract surgery alone most of the time, may have some problems of visual recovery in these patients because of irregular surface, and the corneal opacity per se may not give you good results. Corneal fused endothelial dystrophy, another large group of cases where you do have problems. There's an algorithm described by various institutions how to tackle these patients. The major problem is if they have a thick cornea and poor endothelial function before surgery, you're going to have a corneal edema subsequently, especially central area, and that may be a cause of non-improvement subsequently and patient being unhappy with results of your surgeries. And this edema requires a treatment which may go on for 3 to 6 months sometimes, and may be the cause of unclear vision in these patients. They have been patients who have 6/6, but their vision is not very clear because of a thick cornea and edema which is there. And Salzman corneal nodal degenerations are very common in Indian scenarios because of various regions of inflammatory disorders like trachoma and allergic disorders. Sometimes they may be in the central area, which may be a cause for non-improvement. Your IOL power calculation may be a problem in such patients because of irregular surface. And ocular surface disease will come up in these patients in the post-op cases. So these cases you should be very careful. Some patients may require excision of these nodules beforehand and regularizing the surface by a PTK in these patients or a topoguided treatment. Ocular surface disturbance, nicely talked about. It gives you an IOL power calculation problem mainly because of keratometric and topographic problems, which may cause significant cylindrical change which you see with the various topography or keratometry readings. If patient has a significant ocular surface and your keratometry readings are not matching with 2-3 investigations, then you should not be planning a toric implantation or a multifocal in these patients because they will never be happy with your plannings. This, he described worsening of dry eye, which is existing in this age group of patients. They require a proper management approach. Mainly, they would be these are classified into various regions. I would say all patients who have a little bit of MGD, they would require a treatment for a longer period. Cyclosporin, I have not prescribed to many patients, but I have patients who are having artificial tears in around 10 to 15% of this age group of cataract patients. Posterior corneal curvature can change, especially with the wound retraction which happens in a clear corneal incisions, and they may be called a little change in a refractive outcome, and that is crucial for a toric and multifocal patients. Post-ictasia, post-refractive surgery, again, they do have ocular surface problems. The incisions in RK can give you a very poor results, and your IOL bar calculation, whatever method you use, do give you a surprise sometimes. The incision can open up during your surgery and they require suturing as such, and you can decrease the wound-related problem in these patients by suturing. And careful moderation of your phaco energy and your placement of incision is very, very important. They all have surface problems, and that normally accentuates in the post-op period. Same holds to for corneal opacity patients. If the corneal opacity is right in the center, and you can do a little bit of pupillary enlargement or a placement of a sphincterectomy in an area which gives a clear access for visual pathways. These patients are normally, you have to be careful prescribing too much of a steroids or NSAIDs in a post-op period, which normally you give for your patients. Corneal opacity patient, ocular surface disorder patient, the titration of a post-op medication is very, very crucial, and these patients should be thought about separately than a routine case of cataract. Post-keratoplasty, again, epithelial problems, graft rejection can happen because of inflammation. If they are early onset cataract, the sutures will be there, they might cause a problem. You have to titrate everything very, very careful in these patients. Combined surgeries for pterygium is planned in most cases, and sometimes they do well. And especially pterygium, which is less than 3 millimeter size, and they are not progressive. And in these cases, you can do a pterygium excision and phaco in these cases. And you can really change the corneal topography in these patients on the table. And we have a series of more than 100 patients where we've done a simple excision without putting autocons. In this age group, they have done really well. There have been no recurrences in the last 3 or 4 years in a consecutive surgery of phaco and pterygium excision. You can see a nice pterygium excision has been done. If you look into the keratometric values of this patient, it really gives you a real change. Intraoperative causes are also very, very important, especially surgically induced astigmatism. That may be a cause of dissatisfied patient in toric and multifocals. Membrane detachment, which can be a factor sometimes. The localized wound edema in these cases, change in the keratometric values. The regression of this edema will cause change in total refractive power. So surgically induced astigmatism basically depends on incision size, shape, placement, and the distortion which happen in your surgeries. DMD is reported up to 40% on table, and if you do an ASOCT in a post-op period, it can be around 40% subsequently. But most DMD, they resolve subsequently without causing a significant problems. It is less than 10% of cases we may require intervention sometimes by injecting air or some other gases in these patients. If you have a persistent edema, especially in a wound area, you must do an ASOCT to see and delineate if there is a detachment. If you see this ASOCT, there is a large detachment which will happen in this patient, especially in this area. So you have to go from an opposite area, which is a normal limbus, where this detachment is well attached, go through that area and inject gas, which will retain there for a longer period, and attachment or detachment will be perfect in these patients. So if you have a small detachment detachment superiorly or temporarily located, sometimes a simple air injection does well in these patients. But if you have inferior detachment, especially to the side port, it's better to inject gas, which will give a tamponade for a longer period in these patients. You can see first you have to take out aqueous so that you can then inject gas, and that will give you a better tamponade in these patients. And the clarity will improve subsequently. You can see a pre and post, the clarity improves in these patients. TAS, as I said, can be caused in some percentage cases with endothelial damage. They have to be really separated from endophthalmitis in your patients. And sometimes endothelial protection is required in these patients. Endothelial count, especially in a fused patient, is important. The medicine which cause toxicity is basically because of preservatives. Sometimes the newer generation fluoroquinolones can also be toxic to the epithelium. and these patients require immediate discontinuation of these toxic drugs. Always stain your surface and see whatever damage that has occurred, and look for switching to the preservative-free medication if available, and always add lubricants and avoid NSA in ocular surface disorder patients. The melting of corneal surface is seen in these patients. To summarize, you require a very comprehensive evaluation of unsatisfied patients, which goes long way before you start surgeries. Correct K values, intraocular protection of ocular surface. This is important. You can use viscoelastic over the cornea rather than irrigation with VSS or zinc active, especially in weak epithelium like diabetic patients. Make sure your wound is stable throughout your surgeries. If needed, you can put suture, protect your endothelium, and post-op you manage very, very carefully, especially counseling them in a nice manner, which gives you a less difficult time, a post-op period in these unsatisfied patients. Thank you for your kind listening.